And then due to time, we go to the next speaker, thank you so much, which is Professor Dubrovsky from Argentina. And I think Susie-Ann will handle the slides, right?
Okay. Thank you very much for the invitation. So what can be said that has not been already said? I've been asked to tell you about Duchenne dystrophy adult care in Argentina. And Argentina is a very large country, as you know. We are now, the last census, which was a few days ago, we are about 47 million people, and population is mostly concentrated in these large cities, Buenos Aires, Cordoba, Santa Fe, and capital. And now you will have an idea how large is this country and in the next one. And we have all kinds of landscape, from the snow to the very arid parts in the north part of the country. And to have an idea about the size, if you compare this to the US, it goes all across the United States. It's the 8th country in the world in size. And just a few peculiarities about Argentina. We love soccer and we have a god. Probably most of you know our god. And we have a pope, and we have another new god, which is Messi, and for the North Americans, Ginobili, and we have a queen. But let me tell you, it would be presumptuous to talk about DMD care in Argentina as a whole. I can tell you, and I can show you what we think and what is our experience and who we are. And besides being a large country, there are many differences between what happens in the big cities and what happens in the interior of the provinces. And there are cultural and resource-wise differences. And there are many poor regions with very scarce resources above all other basic needs, not only in health, are not satisfied. Example, the northern provinces of the country. There is a great asymmetry and inequity in most instances and in many issues, okay? So about us, we are a large neuromuscular referral center. We receive patients from the interior part of the country and abroad, from other Latin American countries. We started in the 80s, and we take care of many all neuromuscular disease, and more than 35 years working actively with Duchenne dystrophy, formerly at the French hospital and now at the Prof Alberto Foundation. We have an historical database from those times to now of about 1,200 Duchenne Becker patients. And we were, by the way, the first ones in studying the FLAS Accord and showing the benefits of the FLAS Accord with a paper published in 1990. And we are part of the Synergy Network, and we have participated in many trials sponsored by the industry, by us, and by Synergy. And okay, this is another thing that we do. We have with the muscular dystrophy, with the local muscular dystrophy association, we have an extramural care program where we travel to different cities. These are here in the map that you can see them. Rosario, Santa Fe, Tucumán, Corrientes, Posadas. These are cities far away, from 350 kilometers away from Buenos Aires to 1,500 kilometers away from Buenos Aires. These are selected because they are most poor provinces in the north and in the northeast. And we sponsor with the Muscular Dystrophy Association a free Duchenne and neuromuscular pediatric clinics, and in these locations we go 3 and 4 visits per year, and we organize the groups there, and we have many patients. And this is why we see patients since they were kids. Here you see this family, these young boys have now 42, 32, and 37 years old. And this one is another of our patients that got married, and now he has a beautiful girl. And here, this guy was, he was about 8 years old, and now he is receiving here in this picture his degree of lawyer, and now he's 33 years old. He's sitting in his office, and this is another father that we are following for several years. This guy has 40 years old, his brother 28 years old, and all these patients are being seen for quite a long time since they were kids. This patient has 35 years old, and this person is our master evaluator, our physical therapist who is working with us since those times, Jose Corteri. And another example here, he was 8 or 9 years old. Now he's 34 years old. We still follow these patients. And another one, we think that, okay, another thing, what can we say that we do, in what are our standards of care? Our standards of care are the same as the ones in any other part of the world. We do the same things that everybody does in following up these patients. But let me talk a little bit about transition, because as you know, transition, much has been said about transition as a fundamental step toward proper care in adult patients. And transition has been defined as a passage. I think it's a process where adolescents with chronic diseases from pediatric to the adult care system. And then there are medical needs, psychosocial needs, educational needs that need to be considered through this process. And there are well-established guidelines for an orderly transition. These guidelines have been published, in the Lancet. These are the famous Lancet guidelines. However, the transition is largely dependent on local resources, geography, type of health service provided in a particular country. This is the guidelines are a sort of an ideal situation, but this is not always the case. In many instances, at least here and in many other countries, clinics and hospitals may have age limits for patients, for the patient to being followed up after 16 years. They are thrown away from the pediatric centers to adult care centers. And this is a problem. This is a real problem, So we think that neuromuscular centers and specialists should be able to follow up patients regardless of their age in the same team. For both the family and the patient, losing the possibility that the physician who has cared for him all his life will continue to care for him just when complications begin to appear represents a major problem. They want to keep with the same physician, or at least with the same team. So that's why we think that neuromuscular centers should have specialists that will be able to follow patients since childhood, through adolescence, and through adulthood. And for us, this is an important issue. There are many challenges with the transition problem. You know that as age progresses, there are more complications, and on the same time, the frequency of follow-up visits goes down. This is a problem that we see, and it doesn't change through the years. Reasons are because, okay, the progression of the disease, you have more muscle weakness, you have loss of function, contractures, scoliosis, respiratory involvement, cardiological involvement, medication side effects as age progresses. And frequency of follow-up visits decrease because patients are fatigued, there is some discouragement, there is some sort of resignation, I would say, difficulties in traveling to the hospital or to the office. There are other children in the family problem, many divorces, the cost increases, bureaucratic obstacles depending on the health system, and we have a lot of them here, disappointment, resignation, the parents are older, and so it makes, when you need more control because you have more complication, the problem is you get less frequency of follow-up visit and control. And something that I think has come from the pandemic, and it's very good, is telemedicine, and somebody else is going to talk about telemedicine, but it has been very useful in these instances for us to control the patients, to have a follow-up visits, that patients that cannot come to our center. Another problem is the problem with the adult neurology. Once the patient leaves the pediatric facility and goes to an adult facility, the problem is that neurologists, adult neurologists, are not familiar with complications in Duchenne in adolescents or even in young adults. They are not accustomed to the effects of chronic corticosteroid therapy. They are not accustomed to these fractures and falls and excessive weight and low IQ or learning disabilities, lack of social integration, social and educational problems. Remember that the child neurologist or the child physician works with the families, but the adult neurologist or physician is not used so much to work with the families. So that is again why we think that this should be under the same team, under the same care team. These patients shouldn't change from pediatric center to an adult center, which are not connected or which don't work together. Then all these issues that are pointed out here, reluctance to follow-up visits that are more necessary, progressive scoliosis, wheelchair rejections, adult neurologists are not used to manage these problems. And this is a problem, again, with adult care in many, many countries. And so lastly, I want to show you what we did with a group of our patients many years ago, a few years ago, I would say. We took just data available from 46 patients from our database between 25 and 30 years and more than 30 years. And of course, all these are Duchenne. And we did some study to see what new things we are seeing in our practice, what new issues are to be considered in these patients. Many of those new issues have been already discussed yesterday. And something that we found that it was interesting in this study, that we found that the percentage of patients able to complete the secondary and tertiary studies in this particular group is strikingly high according with the usual standards for the DMD. Of course, many factors need to be considered. This observation in principle could support the idea, we think part is maybe true, that the better cognitive profile coincides with more prolonged independent ambulation and possibly longer survival. These patients are more determined to continue to work, but this is just an hypothesis and needs to be proved, okay? And the other thing that we found is what has been said yesterday: constipation and formation of fecal omas is a great problem. We have acute problems. 3 patients developed severe intestinal obstruction, and 1 died due to intestinal perforation. So as age increases, constipation is much of a problem. The same thing, it was said yesterday, and we can confirm that as increases the age, you get more and more swallowing difficulties. This is a correlation between age, swallowing difficulties, and constipation. So this is something that needs to be taken very seriously as the patient grows up. And there are other life-threatening complications that patients develop sort of a cardiogenic shock and when they have a minor injuries, like a fall apparently without any consequence. And this is also has been outlined yesterday by the endocrinologist, who said that a reinforce of corticosteroids should be given in those situations. And we found a high percentage of depression in many of the older patients that need to be treated. So these problems are different than the ones you see when you have young DMDs. Older DMDs are different, I would say, a different phenotype, and you have to consider and to take care particularly of some of these issues very special. And okay, I think my time is up, and I thank you very much for your attention. I don't know what happened with this slide. No. Okay, here it is our working group. Thank you very much, and see you promptly. Thank you.